Myasthenia gravis is a chronic autoimmune disorder that interferes with communication between nerves and muscles. It is not especially common, affecting between 9 and 30 people per million in the United States, but it carries significant clinical importance because of the way it weakens voluntary muscles and can lead to life-threatening complications. The condition appears more often in younger women, usually in their 20s and 30s, but after the age of 50, it is more often diagnosed in men. Pathophysiology. To understand myasthenia gravis, we need to review how normal muscle contraction works. At the neuromuscular junction, a nerve impulse releases acetylcholine into the synapse. Acetylcholine then binds to receptors on the muscle end plate, causing the muscle to contract. For sustained contraction, acetylcholine must continuously occupy those receptors. In myasthenia gravis, autoantibodies block or destroy many of the acetylcholine receptors, leaving far fewer available for binding. With fewer functional receptors, the signal from the nerve does not translate efficiently into muscle contraction. The result is weakness that worsens with continued activity and improves with rest. About 85% of patients test positive for these acetylcholine receptor antibodies. Many also have abnormalities of the thymus gland, either thymic hyperplasia or a thymic tumor, which is thought to be a source of antibody production. In those who test negative for the classic receptor antibodies, other antibodies may still target proteins at the neuromuscular junction. Clinical manifestations. The presentation of myasthenia gravis can vary widely. Some individuals have disease confined to the eye muscles, which is known as the ocular form. In these patients, double vision and drooping eyelids, or ptosis, are typical. In the generalized form, weakness extends beyond the eyes to include the face, throat, limbs, and even respiratory muscles. Weakness in the face produces a flat, expressionless look. Involvement of the larynx and throat muscles causes difficulty speaking, known as dysphonia, and difficulty swallowing, or dysphagia. These problems increase the risk of aspiration and choking. When the respiratory muscles are affected, patients can develop respiratory failure, an emergency known as a myasthenic crisis. It is important to remember that myasthenia gravis is a motor disorder only. Sensory pathways and coordination are not affected. Assessment and diagnosis. The classic diagnostic test is the acetylcholinesterase inhibitor test, most commonly performed with edrophonium chloride. When given intravenously, edrophonium briefly prevents the breakdown of acetylcholine, allowing more of it to remain in the neuromuscular junction. Within about 30 seconds, patients with myasthenia gravis experience a noticeable but temporary improvement in muscle strength, especially around the eyes. Because the medication can cause serious side effects like bradycardia or bronchospasm, atropine must always be available as an antidote. For patients who cannot undergo this test, such as those with heart disease or asthma, the ice pack test can be used. Holding ice over the eyelids for 1 minute may temporarily improve ptosis. Blood tests for acetylcholine receptor antibodies are also used, as are electrophysiologic studies. Repetitive nerve stimulation typically shows a decrement in response, and single-fiber electromyography is nearly 99% sensitive for detecting impaired neuromuscular transmission. Imaging of the chest with MRI or CT may reveal an enlarged thymus or thymoma. Medical management. Treatment focuses on improving function and reducing circulating antibodies. The first-line drug is pyridostigmine bromide, an anticholinesterase medication that prevents the breakdown of acetylcholine and increases the chance that it will bind to the limited receptors. It must be given multiple times a day, and patients are educated about the importance of taking it on schedule. Side effects can include abdominal cramps, diarrhea, and excessive salivation. If symptoms persist, immunosuppressive therapy is often added. Corticosteroids such as prednisone are commonly used, starting daily and then tapered as symptoms improve. Cytotoxic agents like azathioprine may be required in patients who do not respond well to steroids. IV immunoglobulin can be used for acute exacerbations or as adjunct therapy, producing short-term improvement within days. Therapeutic plasma exchange, in which circulating antibodies are filtered out of the blood, is another option for rapid but temporary relief. Surgical management. Thymectomy, or surgical removal of the thymus gland, is the only intervention that can lead to long-term remission. It is most effective in younger patients, especially within 3 years of diagnosis. Around 1/3 of patients may achieve complete remission after thymectomy, though improvement can take months to years because T cells have a long lifespan. The surgery is ideally performed in specialized centers, and patients often require preoperative stabilization with IVIG or plasma exchange to minimize postoperative complications. Complications. The most serious complication is a myasthenic crisis, which occurs when weakness becomes so severe that the patient can no longer maintain adequate ventilation or protect the airway. Triggers include infection, medication changes, surgery, or pregnancy. In contrast, over-medication with antibody drugs can rarely cause a cholinergic crisis, which also leads to profound weakness. Both situations require careful respiratory monitoring, with intubation and mechanical ventilation if necessary. Suction, chest physiotherapy, and sometimes enteral feeding are needed if the bulbar muscles are too weak for safe swallowing. Nursing management. Because myasthenia gravis is chronic, much of the nursing role centers on patient and family education. Medication management is critical. Drugs must be taken at the same time each day to maintain stable blood levels. Even minor delays can result in muscle weakness that makes swallowing or breathing difficult. Patients are encouraged to keep a diary of their symptoms to identify when their strength is best and adjust daily activities accordingly. Energy conservation strategies are essential. Patients are guided to schedule demanding activities for times of peak medication effect and to rest before meals. In a 2-story home, commonly used items should be available on both floors to reduce unnecessary stair climbing. Handicapped parking permits, consistent daily routines, and regular sleep patterns can all help preserve energy. Nutritional support is another focus. Meals should be scheduled during times of maximal strength, and patients should sit upright with the neck slightly flexed while eating to reduce the risk of aspiration. Soft foods with sauces are easier to swallow, and large meals are best eaten in the morning when strength is greater. If choking is frequent, referral to a speech-language pathologist is appropriate, and suction equipment should be available at home. Ocular symptoms also require attention. Artificial tears help prevent dryness, and eyelids that do not close completely can be taped shut for short intervals. Glasses with eyelid crutches or prisms can assist with ptosis and double vision. Finally, nurses teach patients and families to recognize triggers that can exacerbate symptoms or precipitate crisis. These include respiratory infections, emotional stress, extreme temperatures, certain medications, and overexertion. Support organizations such as the Myasthenia Gravis Foundation of America can provide education and community resources. Myasthenic crisis. When crisis develops, patients are admitted to intensive care for close monitoring. The priority is respiratory support, with ventilatory assistance provided as needed. Pulmonary function tests like vital capacity and negative inspiratory force are used to detect impending respiratory failure. Arterial blood gases and electrolytes are monitored along with intake and output. Chest physiotherapy and suctioning are often needed to clear secretions, and sedatives or tranquilizers are avoided because of the risk of respiratory depression.